Okay.
Yeah.
I'll just say Dr. Govind Babu is my teacher. He has had many students gone through under his this thing. So whatever he has said, I will, without discussing, without arguing, will say I follow whatever he says. He has more knowledge than me, and he definitely has put good thoughts behind it. But all the patients with newly diagnosed CML in India should receive a second generation TKI. Will Dr. Govindwari will go tomorrow in his clinic and say no imatinib, everyone should be on second TKI? Probably no. When I say all patients should, the newly diagnosed CML-CP in India should receive imatinib, I'm not saying I'm imatinib. We have all these 5 options, but that doesn't mean we have 4 options and no imatinib. The topic is all patients should in India should receive a second generation TKI, which I argue the imatinib also is a reasonable option. Not everyone should receive imatinib, but we have a good choice. We should not be just calling off imatinib because the other TKIs are available. As I said, these are the discussions he has put forward. The prices have come down. We have a more deeper responses, more TFI. So these are the only reasons all people should be on next generation. I will say no. These are ELN 2020. We have now discussed. I'll just read what has been written. All randomized studies comparing imatinib 400 once daily with second generation TKIs, imatinib 400 with a dose increase or imatinib combined with the interferon or low dose cytarabine have failed to improve overall survival. So there is no survival advantage whatever you do apart from imatinib 400. No, another point, no new serious late side effects of imatinib have surfaced over 20 years. I think that's the best part of the imatinib. Someone who doesn't want a TFR, someone who doesn't want to have a more deeper responses. We know if you achieve a cytogenetic response, or even if you achieve a MMR, the chances of progression is very minimal and very good side effect profile. We have a spectrum seen over the 20 years. Would you like to call up that drug which has been proven itself for last 20 years? The panel does not recommend a first line second generation TKI or change to a second generation TKI for faster deep molecular response, but agrees that change may be considered in selected patients. So I agree with this recommendation. The change is recommended in selected patients. It does not recommend a first line second generation TKI in everyone, and does not recommend a change in everyone. So ELN is like a Bible or Ramayana for us, and this is a new one. There's a recent published in March 2020. I think there's no reason we should be arguing against it. A change from second generation, in fact, there's the other way around. The change from second generation TKI to imatinib can be considered when no DMR is achieved within 5 years. You note this, to avoid the risk of serious cumulative toxicity of second generation TKI. So you can go back to imatinib to avoid cumulative toxicity of second generation TKI. So someone who does not achieve a deep molecular response, you want to avoid a toxicity, you need to be on the first generation rather than on second. So second generation TKIs have a serious cumulative toxicity rather than we have 20 years of imatinib. This is the cumulative incidence of deep molecular response. If you see a CML study 4, the imatinib MR4 was 68% at 5 years. If you see anestin, nilotinib MR4 is 66%. So if you compare the imatinib MR4 versus the nilotinib MR4, why the imatinib in MR4 was lower in anestin, I think we should review that data carefully. There's some problem, but if you see, even with the single dose, the CML study 4, German study over the 10 years is a long-term mature data, which shows you a good deeper response even with the imatinib, which is comparable to the nilotinib MR4. Even a MR4.5, imatinib 53 in CML4 versus nilotinib 4.5 and anestin trial. So I don't see why imatinib doesn't give us a long-term response. Everyone talks about the TFR. This is from ELN 2020, where this is written 80% of the patients will never achieve TFR. For these 20% of the patients, you can put it on the second generation, talk about the TFR. Someone who is 80, someone who is 70, someone who is 65 with the multiple comorbidities, you know you are not talking about TFR. 80% of the patients, even if you try to achieve a EH, will never achieve a TFR. There we are looking for a toxicity. Patient will not mind continuing a drug with a minimal toxicity versus a 20% chance of looking at TFR with a more toxicity. Who should not be on second generation TKI? Someone with a low so-called score. If you see this NCCN guidelines, low so-called score, there is a recommendation one, you can use imatinib. Old age, we are not talking about the TFR, we are talking about the comorbidities, we are talking about the age-related side effects. Patients with the comorbidities should not be on the second generation TKI because there is a cumulative toxicity. We should respect a patient's preference. I will say I have all these 5. I'll discuss with every patient whichever suits him, because all these 4 at least have been recommended as a first line. And as I said in ELN, none of them has been preferred over the other. This diagram shows you, as long as you achieve a less than 10% at 3 months, whether you use imatinib, there is no data to show you if you achieve this 3 months 10%, even with the imatinib or nilotinib or dasatinib or anyone is better than imatinib. So I strongly feel we can have a patient who achieves an adequate response and can be on imatinib with the same long-term survival and lesser side effects. This is as long as I'm going into the green, this is NCCN guideline. Why should not I be on imatinib rather than on second generation? I don't see any reason someone who is achieving these green zones should not be on imatinib. Why? If he goes into yellow, if he goes into red, we always have an option of changing. This is a low score. You see a category 1 recommendation includes imatinib along with all these 3 these things. Go through the toxicity profile. There is not a single big organ is involved with imatinib. Muscle cramps, fatigue, edema, nausea, diarrhea. No heart, no liver, no kidney, nothing. Nilotinib, the heart, cerebral, vascular. Dasatinib, pleural effusion, pulmonary hypertension, and prolonged QTc. Bosutinib, even there is a pancreatitis. So all these 3 have a difficult to manage side effect profile. Imatinib, all the side effects slowly goes down with the continuation of the drug. This is the Tidal 2, which we were discussing, and it shows you if you start on imatinib, having an adequate response, you can change it and have a similar outcome. I'll just go through the key point. Using imatinib to treat CML first line with a selective nilotinib switching leads to the excellent molecular response and survival. This strategy may be preferable to the universal first line use of more potent, considering a toxicity, efficacy, and economic factor. So this is not me. This is the Adelaide group recommending this trial. How much is our experience with the upfront second generation TKI in India? We are talking about India. How many publications we have? We have a lot of publications with the imatinib. Any big publication on the second generation TKI from India? We will talk about the second generation when we have a more experience. It's just we have got one or two generics recently. That doesn't mean we should be putting everyone on the first line, second upfront TKI. These are my argument. I will say someone who requires a TFR can discuss about the early deeper responses, but someone who is the older age with the comorbidities, we can think of imatinib is a safer drug among all these 5. So we have many upfront choices, including imatinib. No, everyone should not be started on second generation TKI. We should take care of the age, goal of the treatment, toxicity profile, and comorbidities should guide us. Thank you.